Assalamu alaikum. Dr. Arshad Mahmood here. In this brief video, we are going to learn about the foreign body inhalation as well as ingestion. We will describe the radiological appearance of the foreign body inhalation and ingestion, and we will briefly discuss the management plan of both of these. It is a food for thought lecture. Detail can be learned from the your textbook. So you know very well that from the age of 6 months to 6 years, the children are prone to foreign body inhalation as well as ingestion. There are multiple reasons for that, including the poor swallowing reflex and the structure of trachea and esophagus is such in that age that make them prone to the foreign body inhalation as well as ingestion. And child in this age are easily distracted during the process of eating or drinking, so these make them prone to these conditions. First question that comes in mind is during the seeing foreign body in the trachea or esophagus is that whether the foreign body is in trachea or esophagus and how we are going to differentiate them. And the important thing is that whenever you come across a case of foreign body inhalation or ingestion, you have to do the X-ray, chest, neck, and abdomen. You have to get the two views of neck and chest, while the AP view of the abdomen to differentiate all these things. That a question that I have initially arisen that whether the foreign body is in trachea or in the larynx, trachea or in the esophagus. How now to know to gain the concept of this differentiation, I would like to revise you anatomy knowledge. This is a picture showing the laryngoscopic view of the trachea. You know very well that the structure above the trachea is the larynx, and larynx is having vocal cord. They are arranged in such a way that the gap is maximally in the epidiameter. So any foreign body like coin or other flat foreign body will be lodged in such a way that it will be facing anterior posteriorly. However, if you see the next image, then you can appreciate that behind the trachea is posteriorly is the esophagus, and esophagus has widest diameter in the in lateral side to side. So any foreign body like of coin will be lodged in such a way that it will be having maximum diameter in side to side ways. So considering this knowledge of anatomy, if we apply it on the radiographs, then we can see it in here. In upper part we see the foreign body in the trachea, in lower part we see foreign body in the esophagus. In the trachea you can see appreciate well that the coin is in the AP projection, the coin is having side view, while in the lateral projection it will having it is appearing as a circular, complete circular coin. On the contrary, in esophageal foreign bodies, the AP view will showing uh, complete circular coin, while the lateral view is showing the side of coin. So this is because of the anatomy of these two structures. So the first we will discuss the foreign bodies in airway. This is the revision of your anatomy knowledge. As you well know that the right bronchus is wider and shorter and more in line with the trachea. So the right bronchus is more prone to the foreign body inhalation. In cases of foreign body settles mostly in the right side. These are a few radiographs showing radio opaque foreign bodies in the right side of the chest, in the right main bronchus. Again, a radiograph showing the foreign body that is radio opaque and in the right bronchus. Now, most of the foreign bodies that you come across during your clinical practice are the radiolucents, so they will not be visualized on the plain X-ray. So for that, you have to go for the indirect signs of on the radiograph that include the hyperinflation. Now what happens that foreign body act as a bell. Foreign body behaves like a bell valve phenomena in which the air can go inside the lung but cannot go outside. So air trapping occurs. If foreign body is very large, that it can lead to blockage of the airway and can lead to atelectasis and compensatory hyperinflation. So if you see a X-ray chest with a in which there is a difference in the volume of the two sides of the lungs, then a foreign body is a possibility if the history is suggestive of. So these are indirect signs of foreign body inhalation. Again, in radiograph showing the right-sided hyperinflation, and it is a case of a foreign body. So bell valve phenomena leads to air trapping, and these are indirect signs of foreign body. Now, if the child is cooperative, you can go for the inspiratory and expiratory films. In expiratory films, these hyperinflation is seen more markedly. In younger kids who are not cooperative, you can take a film during the crying process that is also like expiratory film. So the hyperinflation will be more pronounced during this period. Other radiological investigation that can be done for the foreign body inhalation or foreign body in the airway are CT, chest, and also the more advanced is virtual bronchoscopy, and finally is the diagnostic rigid bronchoscopy. A question commonly asked in the exam setting is that what is the how will you manage the foreign body? Then it will be a rigid bronchoscopy. It is both diagnostic and therapeutic. So in case of foreign body, the most important thing is the history, that history of sudden history of respiratory distress, sudden history of choking. That is the most important point in suspicion of foreign body. Whenever you get a child with suspicion of foreign body, the most important thing is the ABC, the airway, breathing, and circulation. And if patient is stable, then go for X-ray. Otherwise, you can directly go for the rigid bronchoscopy. That will be both diagnostic as well as therapeutic. Next is the foreign body ingestion. Various types of things child can get in can ingest. They can be metallic or non-metallic, and different things can be seen. This is a case of foreign body ingestion with a radio opaque material seen in the stomach area. Again, a radiograph showing a foreign body ingestion with the foreign body seen in upper part of esophagus or cricopharyngeal area on both AP and lateral view. Again, this picture is showing that in the AP view, the whole of the quine is seen, while in the lateral view, only the side of quine is seen. That is typical for the foreign body in the GI tract. Again, a case of quine in the cricopharynx with a typical appearance of the quine in GI tract. Another important foreign body in pediatric age group is the button battery. Important in such a way that it is very lethal, that it in a short period of time it can lead to a very severe damage. It causes damage by two ways. One is by generation of electric current, and second is by the release of their chemicals. So these are different sizes of foreign bodies are seen here, from smaller to larger one. The size are usually measured in the form of diameter. The diameter can range from 5 millimeter to 25 millimeter. So in managing the foreign body, the size is very important. Now, how you will on radiograph you will differentiate that whether the child is having a foreign body, that is quine or battery. If we see the AP view, in case of foreign body that is battery, a double rim is seen. You can easily visualize here. And on lateral X-ray that is shown here, it will have a step ladder pattern. There two steps are seen. One is larger step and other is smaller step. These are the characteristic features of battery. Foreign bodies can be sharp object like safety pin here seen, that is seen in upper part of esophagus. Again, a needle is seen in the stomach, that is also a sharp foreign body. The other foreign bodies are magnets. Multiple magnets are seen in the radiograph and also in the endoscopic view. So foreign body ingestion is managed by the removal, and removal is usually done by the esophagoduodenoscopy, esophagogastroduodenoscopy. So that is the use for removal of foreign body ingestion. Now this radiograph is showing the management plan of foreign body, that is for especially for the button batteries, that how we are going to approach them. So this is only for the button batteries. It is taken from the Nelson 21st edition. So button battery can be in two sides, one is the esophagus, another is the stomach or beyond the stomach. For esophageal foreign bodies, if the child is otherwise stable, so we have to immediately remove the foreign body. Now if the child is not stable, like child is having presented to us later, so patient is having some damage to the esophagus in the form of active bleeding, are clinically unstable, then we have to do the removal of the foreign body, but also we need the help of surgeon as well as general surgeon as well as cardiovascular surgeon, and we may need the investigation like CT angiography for that. Now, if the foreign body that is button battery and is in the stomach or beyond, then the age and the size of foreign body matters for further action. If the age is less than 5 years and the size of button battery is also less than more than 20 millimeter, then we have to consider the endoscopic removal within 24 to 48 hours. If the child age is more than 5 years and the size of button battery is less than 20 millimeter, that we may consider outpatient observation of the child, and we will repeat the x-rays in the 48 hours, and if we can repeat it again on the 10 to 14 days if the button battery is less than 20 millimeter. So in both cases, if on the our limited period, that if the button battery is more than 20 millimeter and 48 are the button battery in the same site, or if the button battery size is less than 20 millimeter and even after performing x-ray after 10 to 14 days the button battery is still in the site of stomach, then we have to remove that for button battery. Next is the foreign body other than button batteries in esophagus. These can be the coins. For that, we go for the observation for up to 24 hours. Now, if the if sharp objects are in the esophagus, like needle, like safety pin, like multiple magnets, so in that case, these should be removed within 12-hour period, and the button battery should be removed immediately within 2 hours, as it will lead to the damage the esophagus. There are some other method other than the OGD, that is esophagogastroduodenoscopy, for the removal of foreign body, that include by using a balloon catheter if proper radiologist is available and the person who is performing have some experience and technique. Other method that can pass the foreign body from the esophagus into stomach is by relaxing the muscle, is injection glucagon. So these things can also be tried. Now, if the some foreign body is past the esophagus and enter into stomach, then the most likely the chances are that it will also pass through that and also pass through the whole gut and will be removed in the stools. It is not the case in case it is not the case for the button battery is different, that we have already discussed. It is for the structures other than the button batteries. So for that we need observation. We will repeat the x-rays again and again on the weekly basis, and mostly these foreign bodies pass in 3 to 4 weeks period. Another important foreign body that we have already described is the magnets. So so if there are multiple magnets have been ingested, then if they can lead to the necrosis of structure. Happens that the gut is having multiple loops, and if two loops are having two magnets at the separate side, they will catch each other and also cause the necrosis of the gut wall that is in between them. So magnets are also a dangerous type of foreign body if they are multiple, or if a magnet is ingested along with some metal object. In that case, even if they are in stomach, we have to remove them. Children also can put the foreign bodies into their rectum, and usually these things are expelled automatically. But if they are not being expelled, then we can go for the endoscopic removal after proper sedation. This was a review and a small video lecture on the foreign bodies. I hope it has made some important knowledge for you people.